Hello everybody, welcome at ESC TV. My name is Jurrien Berg, I'm an interventional cardiologist at the St. Antonius Hospital, Nieuwegein, the Netherlands. And I'm joined today by Gabriel Steg from Paris, who just presented at the Hotline Session 1 the TAO trial looking at IV otemixaban in patients with ACS. Could you briefly tell us what the TAO trial looked at?
Yeah, TAO was a trial of a novel injectable anticoagulant in patients with non-ST elevation ACS. As you know, we have 4 existing options for anticoagulation in ACS: heparin, low molecular weight heparin, bivalirudin, and fondaparinux, and all of them had advantages and limitations. There is no accepted gold standard that is used worldwide. There's a lot of use of bivalirudin in the US, but even in the US, the other agents are somewhat used, with the exception of fondaparinux. In Europe, enoxaparin and fondaparinux are widely used, but not consistently. And in fact, every time I talk to a different physician, I get a different protocol for anticoagulation. It's very striking. And so we were interested in this novel agent, otemixaban, which is an IV injectable agent that has a number of features that make it attractive. It's short-acting, a short half-life, has a wide therapeutic margin and no need for monitoring. It has little renal elimination and no potential for interaction with other drugs. And these are attractive features in theory. But more importantly, it was already tested in a fairly large phase 2 dose-ranging trial called CPACS, which was published by Mark Sabatine in The Lancet last year. And in that phase 2 trial, there was a signal of strong efficacy at mid-range doses for otemixaban compared to a comparator of combining heparin and eptifibatide in the same patient population. And therefore, we embarked to try to replicate this in a large phase 3 trial appropriately powered for efficacy and safety. So we enrolled 13,000 patients in 55 countries with non-ST elevation ACS planned for an early invasive strategy. Patients all received dual antiplatelet therapy, and then they were randomly assigned to either otemixaban or control with unfractionated heparin and eptifibatide. And they were followed up with a primary efficacy endpoint at day 7, which was a composite of death and myocardial infarction, and a primary safety endpoint of TIMI major and TIMI minor bleeding. It was quite a difficult and complex study because it was with 3 agents, injectable, double-blind, triple dummy. And on top of that, we also had to do PK/PD monitoring nested in the study at the request of the FDA. So it was really a difficult study for investigators. But we eventually were able to perform the study. Another interesting feature in the design of the trial is that there was a specific design in 2 stages. In the first stage, we enrolled 2,000 patients in 3 arms with 2 different doses of otemixaban and 1 dose of control. And the DSMB for the study was charged in a pre-specified manner to do an interim analysis at 2,000 patients in each arm and decide according to a pre-specified rule which of the doses should go forward until the end of the enrollment for continued enrollment. And they had a pre-specified rule for futility first and then efficacy. And they, based on futility, they eliminated enrollment in the low dose arm and advised to continue enrollment in the high dose arm. But all of this was blinded. The investigators were blinded. The sponsor was blinded. So we had to build a firewall in the study to be able to do this without unblinding. So we enrolled the patient population we wanted to. It was a typical moderate to high-risk patient population with ACS. The patients did go on to have angiography in 99% of the cases. 2/3 of them had PCI, 5% CABG, and the rest medical therapy. The results are very clear. Efficacy is identical between control and experimental arm. We have failed to demonstrate what we had set out to demonstrate, which was superiority of otemixaban.
No advantage at all.
No efficacy benefit. Unfortunately, there was a safety issue with a doubling of bleeding, and it's a doubling of bleeding regardless of when and how you look at it. Whether you look at major, minor, TIMI major plus minor, whether you look at Berg bleeding, acuity bleeding, regardless of the classification, there's roughly a doubling of bleeding. There were no other safety concerns, but of course that was an important safety concern, so clearly this was very disappointing. We looked at subgroups, and the results were robust and consistent across subgroups with no significant interaction regardless of patient characteristics, their management, radial or femoral access, duration of treatment, time since onset of symptoms, etc. So it's consistent. And then we asked ourselves, did we get the dose wrong? So we looked at the lower dose to see whether that fared any better. And the lower dose, if anything, fared slightly worse, but still had increased bleeding. So really it's not related to the wrong dose being selected. It's clearly, we have a very clear result, and that we have to thank the DSMB for letting us go to the end of the trial, because then that provided an unambiguous answer. We have a clear result that this drug is not appropriate and is not superior to the existing therapy for non-ST elevation ACS patients managed invasively. I think that beyond the mere disappointment that we have as investigators for a novel agent, and obviously the disappointment of the sponsor, there are a number of lessons here. The first one is we didn't see any increase in periprocedural complications, thrombotic periprocedural complications, and we did prospectively look at this very specifically because we were concerned with the previous experience with factor Xa antagonist and increased catheter thrombosis. No hint of an increased catheter thrombosis. Although artemisinin will never be used in that indication, I think this is a reassuring signal for patients who are on oral factor Xa antagonist and need to undergo a procedure. The second aspect, which is worthy of mentioning, is I think that this is a lesson that we need to have large, well-powered trials to really reliably assess the efficacy-safety balance of new interventions, just as was the case for TASTE and TAPAS. The phase 2 study was positive, but the appropriately powered phase 3 study is clearly negative. And that's a lesson that we should be very, very careful in not over-interpreting the results of small studies, even if they seem very positive.
And this new agent was given in patients with an acute coronary syndrome in the early phase.
Yes.
Do you think that's the end of studying these agents in such a in this particular phase of the disease? I mean, we have seen good results with rivaroxaban, for instance, but that was started later on.
Well, I'm not sure it's the end of this, and I'm sure that Ole and George may comment. I know there are studies that are about to start that will study other injectable anticoagulants in this setting. But I think there's a lesson here. It may be very difficult to improve on the efficacy, on the potency of anticoagulants in that setting. And if we look at the recent successes, they were largely derived from interventions that were not more efficacious, but actually safer. It seems that minimizing bleeding is a key element in achieving and reducing subsequent mortality. And I would advise to really think twice about trying to test novel potent antithrombotics without looking very carefully at safety.
Fully agree that we don't have to overlook the effect of bleedings. I mean, there's so many data showing a relation between bleedings and mortality. So it might be that we install too many agents at the same time in those patients. What do you think?
Yeah, I think we are very aggressive indeed, because we superimpose often 3 antithrombotic agents at the same time, sometimes 4, with several of these agents are injectable. We do a lot of procedures in these patients at the same time, and often we haven't had fully the time to really assess the relative ischemic and bleeding risk in those patients, and it's difficult because they often overlap. I think that flexibility, short half-lives are important features of novel agents, and avoiding bleeding or minimizing bleeding is probably the one thing that you want to do if you're going to test a novel agent.
Absolutely.
ESC Congress 365 is your free access to ESC Congress content all year long.